Good afternoon. I think that Piotr will start, if I may.
Okay, thank you very much. I'm happy we can meet and talk on the role of liver transplantation in the treatment of primary hepatic tumors. And let me just introduce ourselves at the beginning. I will not read it, all of this. Professor Bozenna Dembowska-Baginska is the chief of our Hospital Institute Oncology Department. We cooperate since many years on the treatment of all tumors, but particularly we are both interested in the liver tumors. So this is the biggest oncology department in Poland, I think, most busy on the solid tumors. I am a surgeon, transplant surgeon, head of the Department of Paediatric Surgery and Organ Transplantation, and we have no any conflicts of interest to report. And just to give our background in the liver tumors and transplantation, our experience in the treatment of hepatic tumors consists of 180 patients, children treated mostly for hepatoblastoma, 120, and 35 for HCC, hepatocarcinoma, and some less common tumors like biliary rhabdomyosarcoma, sarcoma, or other more rare tumors. Concerning the transplantation, we have experience of transplanting of 65 children with HBL or HCC and very single other oncological indications. So we will mainly be talking about this group of patients, which consist about 7% of now actually more than 900 liver transplantations. So just to introduce I think everybody can notice that the use of living transplantation for hepatoblastoma and less common, but also for hepatocarcinoma in children is observed in many centers. Now about 6 to 10% of patients are transplanted, of pediatric patients are transplanted for hepatic tumors. These are below the European Liver Transplant Registry data, showing that 5.89% actually the percent of children are transplanted for primary tumors. But you must also notice that it is coming down to 80s, when these transplants were much less common. So now I give the floor to Professor Dembowska. She will make introduction.
Okay, good morning, good evening, or good afternoon, everybody. I assume that we are all familiar with all of these tumors. Hepatoblastoma is the most common liver tumor in pediatric patients. It's a rare disease. It represents about 1% of all cancers in children, and the disease concerns small children, toddlers. The median age is around 19 months, and most of the patients are diagnosed before 4 years of age. The rest, of course, you can have an older patient with this disease, but usually it is a disease of very young children. We also know that there is a predominance of males to females. There are more boys than girls with this disease. It's about 2 to 1. And it has been shown from studies that those children have a tendency to be born with their low birth babies, even under 1 kilogram. And it has been also shown that this is a disease associated with genetic disorders or syndromes like Beckwith-Wiedemann syndrome, And of course, FAP. We have to remember that FAP has, if there is a family with FAP, then we think about hepatoblastoma in children. It is an embryonal tumor. Most of the hepatoblastoma are epithelial types, pure fetal, which is a good diagnosis, but also embryonal and macrotrabecular. And lately, I mean, it's not something brand new, but since maybe 10 years or maybe a little less, we know that we have been diagnosing small cell undifferentiated hepatoblastoma, but we know today that this is not a hepatoblastoma, but it is a different tumor of rhabdoid origin, and we call it malignant rhabdoid tumor of the liver. Those are the patients who have low alpha-fetoprotein, less than 100, or even smaller. So we have to acknowledge that there is also another tumor that can be misdiagnosed with hepatoblastoma. And we have to, when there is a diagnosis made, we have to think about rhabdoids when there is alpha-feto less than low alpha-fetoprotein. We know also that some people say that hepatoblastoma is a simple mutation genetic disease because it has few coding mutations, and the younger patients, the fewer somatic mutations in this tumor. But we also know that 80% of the tumors are positive for mutations and deletions of beta-catenin gene, and it is a component of the Wnt signaling pathway. We know the role in different tumors of this signaling pathway, but in hepatoblastoma, the role of this signaling pathway is not yet well defined. And what do we do? What is the standard treatment or management of patients with hepatoblastoma? Now, first of all, we need to see the patient with, usually it's an abdominal tumor, it's a small baby, and what we need to do is we need to, of course, take alpha-fetoprotein and beta-HCG, and then we have all the studies, the CTs, the MRIs, and we need to assess pretext of the tumor. We need to know how extensive is the disease in the liver, or if the disease also is outside of the liver or not. And usually we have patients and we start with, after having all the staging and assessing the pretext, we give neoadjuvant chemotherapy. Then we repeat staging before surgery, which is called post-text. And then the surgeons, together with us also and with radiologists, assess how this patient should be operated on and what kind of surgical treatment the patients will get, resection or transplantation. And after we decide on this, and after the surgery, the patient receives post-operative chemotherapy. And we know that this is a disease that maybe there are surgeons there a lot, but we cannot treat this disease without a surgeon. There are some oncological treatments that don't need a surgeon, but this one definitely needs a surgeon. So we need to have a surgical treatment, radical. We need to remove the tumor. It's like here it says R0 resections, meaning that we don't want to leave anything behind, even not microscopically. And we need effective treatment, chemotherapy, or when we have metastatic disease. And also we have to think about excising the metastatic lesions if we assess that this is a good way to go for these children. And of course, today's topic is transplantation, liver transplantation. So we will maybe concentrate on this. And we know that there are criteria for liver transplantation. In hepatoblastoma, it's easier than HCC, but there are also these criteria are being discussed all the time. And we know that hepatoblastoma, in most patients, we treat them with so-called sandwich strategy, excluding very low risk disease where we have a low pretext 1 or 2, primarily resected, and when we have pure fetal histology, then we're even thinking of no chemotherapy. But this is now under clinical trial. So this disease is treated, like I said, it's biopsy, assessing pretext, biopsy, then chemotherapy. I think there's some missing on this slide. There are some missing information, but I will tell you from my head. So it's pretext, and then it's biopsy, and then it's chemotherapy, surgery, and then adjuvant chemotherapy. And the gold standard chemotherapy agents are cisplatin. This is before cisplatinum time. Those patients, most patients with hepatoblastoma, had very dismal prognosis. And then we have doxorubicin or adriamycin products, which are also added to the treatment for high-risk patients. But there are also other active compounds like carboplatin, vincristine, 5-FU, which are incorporated into trial regimens. Also, active substances are irinotecan, temsirolimus, VP16. And now in Europe, there is a big study, not only in Europe, but the PEHIT protocol. Poland has joined this big study, and it involves the US, Europe, and Japan. So we have a common protocol for children with hepatoblastoma and hepatocarcinoma. Okay, that's why this was. Now you see the whole story. And we know that if you look at this slide, the graph on the right, where Catherine Pritchard Jones published data in 2007 showing the progress in the treatment of most malignancies in children. And just take a look how it was before. In the 70s, it was like 10% survival for hepatoblastoma. And then when the introduction of cisplatinum came, that was around 1980s, the results improved significantly. And now children with hepatoblastoma, more than 80, here in the 2000s, it was already around 80%. Now it's more because we introduced the liver transplantation for these patients. So it was really an enormous progress in the treatment of hepatoblastoma in children. And here on the left side, you see the survival rates for these patients according to pretext. And you can see that we can practically cure around 90% of patients with pretext 1, 83 with pretext 2, and so on. So it's really a great progress in the treatment of hepatoblastoma, and this is achieved with chemotherapy, which has to be efficacious for those patients. Otherwise, it's not possible to cure them. And of course, surgery and liver transplantation. And what do we do with unresectable hepatoblastoma? Of course, we need to cure those patients with liver transplantation, but also, from other studies, we see that we need successful and effective chemotherapy, because chemotherapy controls the disease. It tells us that if we give the patient chemotherapy and the tumor does not respond well, this is a proof of unresectability. We cannot downstage those patients from pretext, for example, 4 to 3. But anyway, so it gives us information if this chemotherapy will help us do a conventional resection or not. And we can confirm chemosensitivity of the primary tumor or metastasis, and it also predicts survival. And the key anti-tumor drug, like I said before, is cisplatin. And of course, the unresectable hepatoblastoma, which we want to qualify for liver transplantation, needs a very careful decision-making process. It's a very careful decision-making process in children with hepatoblastoma. And there are common guidelines for liver transplantation and hepatoblastoma. These are guidelines that came from COG, the American group, CIAPL group, and the German group, where we know that the multifocal hepatoblastoma in all 4 liver sectors, pretext 4 is that those patients are candidates for liver transplantations. Patients with solitary pretext 4 that are that cannot be downstaged to pretext 3 with chemotherapy. When we have involvement of portal vein or 3 hepatic veins or central hepatoblastoma, if a conventional resection does not seem to be possible, and of course no extra hepatic extension. Of course, like Professor Kalicinski always says, and he put this sentence here, that of course the definition of unresectable depends on the surgical team. But anyway, it needs to really, we have to be very cautious in resecting tumors that are not resectable, because the rescue transplantation is not a good procedure for those patients, because the results are poor. In our center, the results are poor of rescue transplantation, contrary to the ones to patients who are upfront qualified for liver transplantation. Now we go to hepatocarcinoma. This is a totally different tumor. It's more like a HCC in adults, but it is not an HCC in adults, because the hepatocarcinoma in adults is not the same as in children, and the other way around. More often, or usually, it develops in normal liver, and this does. We know that adults have cirrhotic livers. Those are most adult patients are those who have, the effect of alcohol and so on, and bad habits. And the results in hepatocarcinoma are not influenced by chemotherapy. And here, when we do radical surgery or we transplant the patients with HCC, talking about children, the long-term survivals are very good. The results are quite the same as for hepatoblastoma. And we also know from different groups and studies that only 20 to 30% of patients are eligible for initial resection at diagnosis. Most of them are, the rest of them, that's almost 80%, are potential candidates for liver transplantation. And like here, it says that in CIAPL 1, 2, and 3, where we were looking at the people who were involved in these studies, we're looking at the patients with HCC with complete resection at diagnosis, and it was really not a large number of such patients that they could undergo a complete resection. And we know that HCC responds to chemotherapy, different protocols. PLADO, which was the first introduced protocol with cisplatin and doxorubicin, and they do respond to this. And adding different, also other drugs or intensifying treatment also results in growing responses, but this does not correspond to resectability. So whatever we think about this, the HCC, in my opinion, you need to think about transplantation in our children, even if they respond to chemotherapy. We also don't want to waste time on chemotherapy when we need to do the surgery and think about transplantation, because the results are really good when we transplant a child with HCC. We have results from from many centers, and also this paper, the first that you see here, comes from our institution, and really the results of transplanted patients are very good. If you look at our study or the last study, where we have 80%, more than 80% of survival, it's really like in hepatoblastoma patients. So there is published data which supports that liver transplantation really adds benefit to our patients with HCC. So we need radical surgery, and transplantation is the option. Here again, just a sum up of data, which is again supporting that complete surgical resection is fundamental. It's crucial for a cure. This is the data comes from the German studies, the North American studies, and the SIAPL studies. It clearly shows that the patients respond, but still, if we don't do a radical surgery, the event-free survival is not good. So again, data supporting radical resection. And here we have put this slide on to show what are the indications for transplantation in hepatocarcinoma in adults. And they created Milan criteria where they want to have a very limited disease in the liver, meaning that the nodules or the tumors, lesions should be less than 5 centimeters, less than 3 nodules, no vascular invasion. If we employed these indications to children, this would not work. So here we put a question: should rules be different for HCC in children? Yes, they should be different. And our study, which we presented, which was the first one on the other slide, shows that the HCC adults criteria, the Milan criteria, do not apply to children. What is the role of chemotherapy? Up to date, there is no data to support the role of chemotherapy. We know that we have some drugs, the TKI inhibitors, which are approved for this indication in adults, and it's not a wonder drug, so it only gives prolonged survival. So we need maybe to find some other drugs for this kind of disease. As for chemoembolization, this, I am not a surgeon, so if you have questions, this you have to address to Professor Kalicinski, not me. But this is really, this disease should be taken very seriously in terms of qualifying patient to transplantation, not doing other things. That's my opinion. So the conclusions from the literature on the role of transplantation in HCC is that most patients, most children with HCC present at diagnosis with disease that cannot be resected, and they should be. We should think about them as candidates for transplantations, as first-line treatment, because the second line is never successful as the first one. I'm not saying never, but it's not as successful as the first one. Even that, though chemotherapy is giving responses, it does not change resectability, and the survival with primary liver transplantations is very good. It's like here says 70 to 90 versus 30 after attempted resection. So now I give the floor to Professor Kalicinski.
Thank you for this very detailed introduction. And now I would like to go through a little bit discussion on the resection versus transplantation, because this is the main disease we have to make when we treat these patients, because as Professor Dembowska told, and I absolutely agree with her, the first surgery is most important for this patient, because any recurrence is always giving a poor prognosis in these patients. So there are several papers on the very extreme or extensive resections versus transplantations. There are very experienced surgeons who can make the very detailed and very extensive liver surgery, and they also published the good data for extensive hepatectomy as an alternative to liver transplant in advanced hepatoblastoma, sometimes with vascular reconstructions, etc. So the 5-year disease-free survival rate in this publications achieves something between 65, 63, 80% in this marginally resectable tumors. So in conclusion, there are authors who may, with the huge experience in liver surgery, perform aggressive surgical resections successfully in some patients with post-X3 and even 4 hepatoblastoma, who otherwise would be candidates for liver transplantation. And of course, they support, or this is with the aim to avoid transplantation, and of course the post-transplant risks of lifelong immunosuppression and all complications which could be attributed to transplantation. On the other hand, I think everybody of us working in the transplant centers could see the risks of extended resections. One of them is a recurrent disease, because there is a very low possibility of good resection margin in these patients. Many of them, they will have angioinvasion. So there is a risk for recurrent disease, which is deathful in many of these patients, sometimes also after liver transplantation. There are also late complications, which we should not forget in these patients, because some of them will develop biliary complications, which will lead to biliary cirrhosis, and within longer time, sometimes a few years, they will develop biliary cirrhosis and indications for transplantation, which are not purely oncologic, but they comes from oncologic treatment and complications. So there are other papers which present series or review papers which present reviews on the treatment of hepatoblastoma with liver transplantation. Of course, so-called unresectable hepatoblastoma with overall survival approaching even 90 or even more than 90%. And in the big series, multi-center series, or some reviews, like in the second publications, they indicate, on the other hand, the low survival rate in the rescue transplantation after attempted resection and recurrence. So despite there are some papers which show improvement in this group of patients, there's still a very no good prognosis in this particular group. So now I would like to show our center experience, how we see these patients, what is our experience, and which patients we transplanted. At the end, we will show few cases which could be interesting for some kind of a discussion at the end of our webinar. So as a transplant center, we mostly get children with advanced disease. So in our experience of 120 of patients with hepatoblastoma, we did primary resection or conventional resection in 72 patients, while in 45 patients we did liver transplantation. 3 patients were given only palliative treatment. So this group consists of patients with median age of 2 years, the transplants were done mostly from living donors, and there were 42 primary transplantations, and 3 patients were transplanted due to recurrent disease. So when you look at the survival rate in our series, in our whole series, it is 80% survival with the follow-up between 6 months and 188 months, with the median of 6 years. But when we look at the primary liver transplantation, when we exclude rescue transplants, the survival rate approaches almost 86% in this group of patients, while none of the patients with rescue transplantation survived for more than 2 years. Most of the mortality was for the recurrent disease, while 3 patients died of other causes. So these are examples of our patients which underwent primary liver transplantations. All of these patients, which are presented here on these slides, are alive and well more than 5 years after liver transplantation. So these are huge, sometimes multifocal tumors, sometimes involving hepatic veins and inferior cava vein, and sometimes central tumors. So these patients were not. The upper slides are at the beginning of the treatment, and the lower scans are at the post-text or at the transplantation start. So these are the patients, unfortunate patients, which underwent hepatoblastoma resection and unfortunately recurrence and finally death after retransplantation. So this is one of these patients with a huge tumor with attempted resection after chemotherapy, recurrence and transplantation, and finally recurrence of the disease and death. And another patient from this group, which died after transplantation. So this is just general algorithm which we use for in our center for the treatment of these patients, which is just what was told before. But of course, I would like to point very strongly that there are criteria which were shown by Professor Dembowska, which were prepared by several organizations, but finally the decision is made always very individually. So you cannot just, these are not so much, precise criteria. There are obvious of patients unresectable, but there are also patients which you consider both solutions. And this is probably the most important and most difficult group of patients. So we always, in these patients, because they are high-risk patients, they are with unresectable tumors, the adjuvant chemotherapy after transplantation is obligatory in our experience. So just summing up this experience, we can obtain good long-term survival rates in patients with, even in patients with previous lung metastasis if they are cleared during chemotherapy, and in patients with vascular thrombosis if a good response to chemotherapy is observed. But outcome is poor if the transplantation is done after incomplete resections or for recurrence of the disease. And now I will go to the hepatocarcinoma. This is, of course, much less common tumor. And we had 35 patients treated at our center. At the age a diagnosis between 2 and 18 years, with the median 8 years. In this table, we showed a type of treatment and the results obtained after partial conventional liver resection and after total hepatectomy and transplantation, which includes 3 rescue liver transplantation in this group, with the follow-up, median follow-up of more than 100 months in both groups. So the final results are 33% survival in the partial liver resection. All other patients died of the disease between 1 month and 3 years after surgery. In the group with which we transplanted, which includes 3 rescue transplantation, 23 patients, there is 19 surviving patients. That means 82.6%. But if you exclude also rescue liver transplantation, there's 85%. This group includes 1 rescue transplant with pulmonary metastasis, which is alive but with too short follow-up, so we don't know the real results. The 4 deaths were of only 2 of them were from disease recurrence. So these are examples of these patients. Most of them were outside of Milan criteria with huge or multifocal disease. Both of these patients are alive and well more than 5 years after liver transplantation. What is interesting, when we made this analysis some time ago, and looked at the results of transplantation for HCC, because many of these children are older, but when we divided, so half of them received disease donor graft, but the results are strikingly different, because among 11 patients with living-related donor, the survival is 100%, while from disease donor is 66.6%. So probably this means the waiting time was longer for the patients who received diseased donor graft, with prolonged chemotherapy, which is not so much effective like in hepatoblastoma. We don't see a very clear explanation for it, but this is really a significant difference. So in summary, most of the children with HCC limited to the liver, irrespectively of other criteria, size, number of tumors, angio invasion, should be immediately listed for transplantation and given chemotherapy, with very individual cases for resection, like single peripheral tumor with possibility of resection with white margin. This, the other patients, we think they should be candidate for transplantation performed as soon as possible. So this living donor transplantation is not always possible, but if it is possible, it shortens the time for the resection, for hepatectomy. So it may influence the final result. So this is a similar algorithm for the patients with HCC. Which we more oriented for qualification for total hepatectomy and transplantation. There is a discussion ongoing also in the literature if it makes sense to give adjuvant chemotherapy after transplantation in these patients, as there's no indication it will help to achieve a long survival, because the key is to remove all tumor or neoplasm during the surgery. Otherwise, the disease will recur, probably in 100% of patients, despite of chemotherapy. So, summary, we conclude that despite the progress in chemotherapy and hepatobiliary surgery, still about 15 to 20% of children remain with unresectable hepatoblastoma, and approximately 70% with unresectable HCC. Primary liver transplantation is the option in the treatment of these children, offering similar survival as in the conventional treatment for resectable tumors. Living-related donor liver transplantation, in the face of depends of course on the local availability of the organs, but may help also to transplant patients in a shorter waiting time, and plan it within the treatment as in hepatoblastoma. This is planned as a surgical treatment in a way of the complex treatment of the tumor. So some data from the ELTR at the end of this presentation. These are the data on the pediatric patients, almost 15,000 patients. So the cancers have the lowest, of course, survival in this group. But as it was taught, also chemotherapy in the early 80s and at the beginning, of course, the results of liver transplantation were improving over the time. So when you look at the changing survival in the cancer group in the different period of transplantation, you can see that in the 90s they were very poor, but during last decade or 15 years, they are really approaching 80% of long-term survival. It's the same by the American registries. The results are improving significantly over the years, both for the hepatoblastoma and hepatocarcinoma. So we finished this main presentation, but we would like to show you some of our, I think, interesting cases, which will conclude our presentation. So I give the voice now to Professor Dembowska.
Okay, so I'd just like to say that those two cases that I will present are not typical, because I thought they were more interesting in terms of, for example, in this case of first symptoms. In the second case, you will see why. Okay, so the first case is a boy who came to us, who was admitted to our center, to Department of Oncology, when he was 4 years old. Up to at that time, he was a healthy child, and about 1 month or a little longer before admission, he started to present symptoms of precocious puberty, which no one noticed. It was a little voice change and enlarged testicles and penis, and the parents did not think it was something special. But when the abdominal mass showed, then they went to the doctor, and at that time, the diagnosis of an abdominal tumor was made, and he was sent first to local hospital and then to us. The family history was unremarkable for any malignancies. He had an ultrasound, and it showed multiple lesions in both liver lobes. Alpha fetoprotein was over 1,000, and he had elevated concentration of beta HCG. It was the norm in our center was below 0.1. And the AFP is same everywhere. So he had both biomarkers elevated. The beta HCG was high, and this explains the precocious puberty in this child. And that's how his liver looked on imaging. He was the pretext was 4, so there was nodules in segment 6, so it was a pretext 4. He had a biopsy, but it was a laparotomy, and he had ascites, hepatic ligament with abnormal vessels, and multiple tumor masses in both lobes. And the surgeons biopsied the liver tumor and the omentum. Histopathology showed hepatoblastoma, embryonal and fetal type. The omentum, the fluid from the abdomen was tumor-free. So due to the pretext 4, he began chemotherapy as for high-risk patients. His lungs were clear, so it was only localized disease. He received cisplatinum and doxorubicin, and he had progression on this kind of, the golden treatment was not efficacious for him. His alpha-fetoprotein rose from this over 1,000 to 131,000. Also, beta HCG also it increased. So we changed the chemotherapy to protocol which you give in germ cell tumors. He received etoposide, ifosfamide, and cisplatinum. That's why I'm showing this patient, because it is outside of the standards. And he received a total of altogether 6 courses, and we saw that the tumor shrunk and the alpha-fetoprotein decreased, also beta HCG. Still, when we did the staging, pretext staging before planning of surgery, it showed that the patients is a candidate for liver transplantation. So the mother was a candidate for the donorship of the liver. And when we started to do all the examinations on her, she was found to have FAP. So she had multiple polyps in the intestines, and really, after this whole procedure, she said that we saved her life, because in one of the polyps she already had an adenocarcinoma. So we looked for another donor. It was a family member, and FAP was excluded. He underwent liver transplantation. It was 8 months from diagnosis, so it was a little longer time than usual. But as you see, we needed to prolong chemotherapy because we were looking for another donor, but he still responded to chemo, so we were not so nervous. And in the explanted liver, it was a mixed type hepatoblastoma with teratoid features, epithelial elements, mesenchymal elements showing bone and cartilage formation, teratoid elements, neuroepithelium, like what you find in GCTs, in mixed GCTs, and angioinvasion was present. So after this procedure, the liver transplantation, we applied vinblastine, 5 courses every 2 weeks. He tolerated treatment very well, and he completed treatment in 3 years ago. No, yes, 3 years ago, and last follow-up was January this year, and he's alive, disease-free. So that's one of our atypical patients, and this is a very sad story of a 11-month-old boy, an Ukrainian patient. He was one of the twins born at 30 weeks gestation with birth weight below 1 kilo. It was 950 grams. And this is a story not from our center. I will show you later what we had no opportunities in this patient, but let's follow his story. The diagnosis of liver tumor was made in January 22, so not such a year ago, and the treatment started in Ukraine. He had an MRI of the liver. This is this picture is maybe not so clear, but that's what we didn't have all the imaging studies from there. He had an MRI of the liver. There was a tumor in segment 7 and 8. His alpha fetoprotein was over 500,000, but he had localized disease. He had a tumor biopsy, which showed hepatoblastoma, mixed epithelial type, and he was put on chemotherapy with cisplatin, which is fine. We saw a decline in alpha fetoprotein, and then he underwent surgery. It was May 10th, so after about 4.5 months from diagnosis, and the surgery was an ALPPS procedure and associating liver partition and portal vein ligation for stage hepatectomy. So he had 2 surgeries. First, it was this associating liver partition and portal vein ligation to cause that the other lobe will overgrow. And then a week later, he had a tumor resection. It was right hemihepatectomy. But unfortunately, there was no microscopic radicality. So the AFP, the biomarker after surgery declined. It was like 10 times lower than before surgery. This was the value 12 days from surgery. And 3 weeks from surgery, on ultrasound, they found a biloma, or maybe early relapse. It was drained, but there was no bile in the drainage. It was written that it's a fluid. And then the AFP started to increase 3 times. So he received the post-operative chemotherapy, again 2 courses of cisplatin. And then they observed steady raise of bilirubin to 11 milligram per deciliter, and MRI of the abdomen showed multifocal liver lesions. And we had, I mean, when you look at his story, it was evident that this patient had a very fulminant progression. I don't know if you call it a relapse or progression. Anyway, he had a very fulminant course of this disease. So he was given chemotherapy with carboplatin and doxorubicin, drugs which the patient haven't received before, and partial remission was observed, mostly a decrease of AFP, and some of the liver lesions decreased. Then he was put on vincristine, irinotecan, and docetaxel. Those are all active compounds, but there was no good response after this chemotherapy. And on the 5th of October, that's 2 months ago, he was maybe a little earlier, but he was referred to our center to assess if there is any justification for liver transplantation. He was cachectic, he had ascites, jaundice, his bilirubin was 20, he had coagulopathy, fracture of both femur bones, his AFP was 26,000. We had a liver tumor board. We discussed him back and forth what to do with him. And the decision was that if he can manage with or tolerate chemotherapy, maybe we can consider this, reevaluate it, and make a decision after this doing. So we, unfortunately, the chemotherapy, which there was not much choice of drugs, was unsuccessful. He received oxaliplatin with progression. Then we put him again on the cisplatin vincristine 5-FU, which is a pretty good, this is an American protocol. And unfortunately, there was no response. He presented with GI bleeding, progressive liver failure, progressive hepatoblastoma, and the patient died like almost not even 2 months from this referral to our hospital. I think this case just shows how important it is to make a decision at the time of surgery, how this patient should be operated on. And thank you. Those are the 2 cases.
And next, please, I will just show very shortly the next case with the infiltration of the IVC portal vein hepatic veins, just to show that sometimes we need, for example, during cleaving-related liver transplantation, to replace IVC, in this case with frozen graft. So different techniques should be used for these patients to remove all the disease, to remove the potential source of recurrence of the disease, like IVC1. And the last case, which is actually under our treatment, which was also discussed by us very strongly, is another child with a large right lobe tumor, diagnosed initially as hepatoblastoma, which was resected already after only 2 courses of hepatoblastoma of chemotherapy in another hospital, with tumor recurrence, with high alpha fetoprotein, with no regression to chemotherapy. He was referred to our center after this unsuccessful treatment. We saw on PET-CT multiple tumors within the liver, but also infiltration of the hepatic hilum, infiltration of the abdominal wall at the place of biopsy, which was done when he recurred after resection. There were no pulmonary metastases. So we qualified him for very intensive individualized chemotherapy with the aim to reevaluation for liver transplantation. He received 4 courses of chemotherapy with regression of the tumors, with drop of IFP to 5,800, and we transplanted. This is just pre-transplant pictures of the CTs and AFP, which reacted really for the chemotherapy. Before the transplantation, we gave these patients indocyanine in green to recognize as much as possible any extrahepatic involvement. So you can see intrahepatic tumor, but you can see also 3 tumors which were implanted in the diaphragm, in the right diaphragm, and there was one also in the left diaphragm, and one in the omentum, and one in the transverse colon wall. So we removed all these metastatic tumors and went with transplantation. He received also 4 chemotherapy courses after transplantation. Our pathologic result showed that within the explant, the hepatocarcinoma picture characteristic signs. So at least it was a mixed type of tumor with hepatocarcinoma, which evolved after treatment of hepatoblastoma. The alpha fetoprotein was down to 150, but then stopped. And at the control CT, we saw bilateral pulmonary metastases, which were removed also with the help of indocyanine green thoracoscopically. At that point, we are of course very afraid of the final result, particularly that just I was told yesterday by Professor Dembowska that the next CT scan showed another pulmonary metastasis, which we are going to remove this Monday, because we think we did so much, we should go for any visible recurrent tumor in this case. So this is the end of our presentation. I don't know if you would like to discuss anything with us. We already filled 1 hour of the time, but it's up to you. I think there are many questions which are considered within the transplant teams and with the oncological cooperation in these patients on the immunosuppression protocols, on the adjuvant chemotherapy, on the place of the liver transplantation in these patients. So just feel free if you want to discuss with us.